Okay, Lenny, we've got a few more people still coming in from the waiting room, but you can go ahead and kick us off.
Great, thank you very much, Laura. And sorry to have started this a few minutes late, everyone. I'm Lenny Shawcross. I'm Executive Director of World Dementia Council. I'm just going to say a few words by way of welcome. This is part of a series of activities the Council is doing, and I'll say a few words about this activity in a moment, but as you can see, we're doing a summit meeting in Peru in a couple of weeks' time in partnership with Alzheimer's Association, and which will be the conclusion of this activity. So before I talk about that, I'm just going to say something very briefly about the World Dementia Council. It was founded by the UK government after the G8 Dementia Summit that was held here in London, where I'm speaking to you from. The Council is a networking organisation for global leaders in the dementia space, and we also provide leadership through producing papers on different aspects of the global dementia agenda. As I very briefly mentioned at the top, we are doing a series of virtual dialogues. I know quite a few of you were here for the last one we did on the Caribbean, but we've also done the three that you can see here on the screen slightly earlier this year and at the back end of last year on the research and with a focus on Latin America. And this is the second of these virtual meetings that we're doing with a focus on the Caribbean. And as you saw at the top, the conclusion of all this activity will be a satellite summit we are holding on the 13th of May in Lima, Peru, ahead of Alzheimer's Association Satellite Symposium, which is taking place on the 14th and 15th of May. And if you go onto our website, /Peru-Summit, you can see more information about both of these events. And the final thing I will say before handing over to the people who've actually organised this meeting is that what we have coming up is a series of activities we will be announcing next month that are looking at innovation in the dementia space, that's looking at how advocacy movements are responding to the development, to the introduction of treatments, and also going to, as our next sort of geography of focus, is going to look at the challenges of dementia in India. So that's me by way of introduction. I will say something at the end by way of thanks, but with that, I will hand it over to Ishtar to take the meeting forward. So thank you very much.
Thank you very much, Lenny. Good day, everyone, and welcome to the second session in the World Dementia Council's Caribbean Dialogue Series for April 2025. I'm Dr. Ishtar Govia, a public health scientist, Caribbean regional advocate, founder and CEO of Amagi Health Limited, and a nominated member of the World Dementia Council. I'm delighted to be co-chairing today's session with Dr. Horace Cox from the Caribbean Public Health Agency. I want to welcome new participants and those of you with us since our first dialogue 2 weeks ago when we focused on diagnosis and health system preparedness. We discussed what it means to plan for dementia in a region marked by data fragmentation, workforce shortages, and regulatory complexity, but also by infrastructure in motion, cross-sector innovation, and clear local leadership. Today, we turn our attention to policy, advocacy, and awareness, asking, how do we mobilize political will around brain health in the region? How can public and private sectors work together to sustain access to care and drive health equity? And how do we ensure inclusive, culturally resonant advocacy that can break stigma and build support across our diverse Caribbean communities? We have 5 distinguished speakers today from academic, clinical, innovation, policy, and advocacy spaces. Mr. John Barnes will remind us of the importance of experience, visibility, and voice. John will be staying with us only for his remarks and then must leave because of a prior commitment. Professor Ian Hambleton will ground us in demographic shifts and the policy implications of a fast-aging Caribbean. Dr. Seb Walsh will share lessons on population-level prevention and structural risk reduction. Mr. Avinash Saxena will speak to health innovation ecosystems and the critical role of public-private partnerships. And Dr. Chelsea Garcia will reflect on integrated home-based care models and long-term care inclusion. Apologies from Dr. Karika Weldon, who is not able to join us today because of unforeseen circumstances. Before we begin, a few quick reminders. Please keep your cameras on if you're comfortable. This is a dialogue, not a webinar. Speakers will offer short provocations, about 5 to 8 minutes, and after all speakers have spoken, we'll open the floor for discussion among you or other experts. Please feel free to use the chat or raise your hand at any point. This session is being recorded. Finally, I want to share a save the date for the Caribbean Brain Health Summit in Jamaica in November 2026. See these details on the flyer. With that, I'll now hand over to my co-chair, Dr. Horace Cox of CARPHA, who is the Acting Director of Surveillance, Disease Prevention and Control, with a current portfolio that includes efforts to improve health data systems integration through platforms like the District Health Information System version 2 and other initiatives to enhance syndromic surveillance in the Caribbean. Dr. Cox, over to you for a few words of welcome.
Thank you very much, Ishtar, and also to the colleagues who are on the call for the opportunity for CARPHA to participate in this important conversation, as you've said. We do note that there are several policy implications that are tied to dementia, and of course, CARPHA's commitment at the Caribbean regional level is to improving the health status of Caribbean people across the region to ensure that they're healthier and of course that they can enjoy a better quality of life. And because of that, we have assessed that dementia, as you've spoken, threatens that directly. And because of our commitment as a regional public health agency to improving this, we're happy to join with you and other colleagues in terms of co-chairing this conversation, and of course, to listen to the experts as they share their experiences. And I hope that it will only stimulate conversations moving on. I think that as a Caribbean Public Health Agency, we're well positioned to be a strategic partner in this effort and to be able to share with you in the experiences and also to help in some of the translation to policy for some of those things that we identify as good practices. So I really hope that this can not only stimulate conversations today, but that hereafter we can continue to work closely to ensure that we can deliver this in a very robust way that also the people of the Caribbean can benefit directly. I was pleased to note the plans for the summit, which is in 2026 in Jamaica. And of course, there's the opportunity for stronger Caribbean participation there. Now, having said that, I am quite pleased to co-chair this and looking forward to some very robust exchanges. Thank you very much and kindly yielding back.
Thank you so much, Horace. So now we turn towards our speakers, and first we will turn to Mr. John Barnes. So Mr. Barnes, you have been very open about your family's experience with dementia and have actually lent your voice to efforts to raise awareness around both personal and sports-related risks. As somebody from Jamaica and with deep ties to the Caribbean, how do you see public figures, especially from sports and entertainment, playing a role in breaking stigma, encouraging timely diagnosis, and shifting public and policy attention toward brain health in our region? You're muted, John.
Thank you very much for having me, Ishtar. You're talking as if you don't know me, because before you're calling me Johnny, and I was wondering whether people knew who Johnny was, but that's me, Johnny Barnes, to my family, of which you are one, and now you've adopted a very professional tone. Thank you very much for that. I look at it in a very holistic way. I look at this in terms of, first of all, if you look at the adultification of young black boys in the system in England, whereby they're treated differently because of the perception of them. And I think from a mental health point of view and a dementia point of view, but talking about mental health, I think it's also very similar. And the misdiagnosis of Caribbeans who are considered to be aggressive, and in terms of the way that the police actually treat them when they actually come to them. So it's very similar to the way black people generally are treated because of the understanding of them generally. Even in the medical profession, I've got two doctors in the family, and if you look from a medical profession in terms of the diagnosis, not from a mental health or dementia point of view, but just in terms of normal treatments that you assume would be for human beings. Obviously, from a Caribbean or Afro-Caribbean or African point of view, there are different issues that they have with the rest of society. And I don't think that that has been examined enough. But that's definitely from a mental health point of view or from a dementia point of view, obviously different people are treated differently and they have different needs. And I don't think that we've really explored that in this part of the world, in England particularly. I can't speak for the Caribbean, but in England, I know that there's lots of misdiagnoses. Obviously, you know, as you say, I have issues in my family with dementia, but that's in Jamaica and America where maybe things are different. But in England, I think Afro-Caribbeans, generally speaking, in the medical profession, are not understood even from a genetic or a biological point of view, never mind from a mental health point of view.
Thanks, Johnny. Do you have any thoughts in terms of, given how significant Caribbean people draw to music and to sports, is there a stronger role that you see sports people like yourself, other generations in sports, music, entertainment? What role do you see them being able to play in raising awareness and doing advocacy in the Caribbean?
Of course, that's a big issue and a big question, and we've seen it in all walks of life in terms of, you know, high-profile elite black people, and you talk about representation. But of course, what generally happens until we change the perception of the average black person, that is still going to be an ongoing problem, because what will happen, as we've seen from a sporting or music perspective, where they bring it to the attention from a mental health point of view, yes, if you are an elite black person, you will be given opportunities and support because you are elite. That's not going to help the average black person in the street. So while we as celebrities can bring the problem to the fore in terms of from a mental health, from a medical point of view, from a representation point of view, society will at large still just look at it that we need to get more black doctors and black lawyers and black actors and black footballers. What about the average black working class person? So there's not a lot we can do about that from a celebrity point of view until we change the perception of the average black person. All we will then do is elevate the elite black people out of these positions of power, and then say, right, well, let's help them. Let's help Idris Elba get an Oscar. Let help John Barnes get a job. But what about the average person? And I suppose from a white perspective, white working class people go through something similar. But from a black perspective, yes, it's about starting the conversation and bringing it to the fore. However, is that really going to help? Because all that does, it helps the elite black people. Like from a mental health point of view, we know that if I had a mental health issue, I will be seen. But how is that going to help a young black boy in Brixton? The perception they have of him is not going to be the perception they have of me. So while it is good to start the conversation, we have to wind the conversation and look for advocacies in the inner cities with, you know, people who work for the councils, and, you know, those people are the ones who really on the ground who should really do it. So yes, we can bring the conversation to the fore, but we have to then move away and say, let's take it down to the ground level.
What would you say to a policymaker in terms of some of these issues that you've mentioned? What
well, of course, policymakers are, I mean, I'm not, you know, knowledgeable enough to know from a policy point of view what's necessary, but I do know that a lot of people are like boxes to be ticked in terms of from a representation point of view, yes. And if you want to take it a bit further, to say we had a female prime minister, didn't we? And but an Indian prime minister, but that has helped the average woman or the average, you know, Muslim or the average Indian person, no. So from a policy point of view, I am not the person for that to understand. There are people much more, you know, knowledgeable in that aspect as to what should be done.
Okay, gotcha. Anybody from the audience have a quick question for John before he leaves? Johnny.
So they're calling my flight to Ireland in a second, and they're trying to get me off this desk.
All right. Well, Johnny, thanks for taking the time, especially right before you fly. Really appreciate it. And
a pleasure. Thank you.
So you being part of more conversations.
I'd love to bat to you as well.
Well, lots of love. Bye. All right.
I'm all finished now. There you go.
I think thank you. So Horace, now over to you to introduce our next speaker.
Thank you very much, Ishtar. And noting too that Johnny got us off there with a lot of energy, which we appreciate. I'm sorry that he had to leave, but we're very thankful for his intervention. Next, I have the privilege of introducing Professor Ian Hambleton. Professor Hambleton has worked on how population aging is rapidly shifting the health landscape in the Caribbean. Professor Hambleton, could you walk us through what it means for how we prepare at the policy and systems level for the rising burden of dementia and other age-related conditions? Thank you.
Great. Great to be here. Thanks very much. Nice to see everyone. I will let's see if the slides do that and answer the question, and of course shout if they don't. Let's give this a go. So I'm going to share my slides. And hopefully you can see that as full screen now.
I can see,
yes.
and it's in presenters mode. Thank you.
Yeah, perfect. All right. Yes, so hi everyone. So what I'm going to do today is give you some demographic background to the trend of rising chronic disease and dementia that we're seeing across the Caribbean. The work comes from recent analyses that we've completed with PAHO. I'll share the web links to these reports at the end of the slides. Both reports, though, came about thanks to a new project with IDB, so that's the Inter-American Development Bank, which is helping to expand access to health data across the Caribbean. And I'm going to mention that with your permission at the end of the slides. So over the last couple of decades, we have seen the remaining life for 60-year-olds in the Americas increase from 21 to almost 23 years. That is higher than any other world region. So that sounds very positive. Regional averages, though, as always, will hide important evidence. And when we compare Barbados, just as an example, to that regional average, we start to wonder if something else is going on. Years of remaining life in Barbados still increasing, but at a much lower rate. And in fact, when we include every Caribbean country on the chart, we see 27 of the 32 Caribbean territories have a lower life expectancy than the regional average, only 5 higher than that regional average. So let's stay focused on Barbados just as an example. In Barbados, death rates from NCDs are dropping. That's thanks to public health advances, health system improvements, more generically, thanks to social improvements, of course. Lower death rates, of course, lead to aging. We've got 10,000 additional older adults in Barbados now compared to 2000. By 2060, we expect the proportion of Barbados women over 70 to more than double to about a quarter of the population. Proportion of Barbados men over 70 expected to triple to almost a quarter of the entire population as well. Let's take a look how that might influence levels of illness that we're seeing from NCDs. So what I'm doing here is using a summary of illness called the DALY, Disability Adjusted Life Years. That's 1 year lived in less than good health, which is a curious term, but think of it as a year lived with illness, effectively. Those public health advances that I mentioned on their own would have led us to about a 7% decrease in illness in Barbados. So if nothing else was happening. However, the aging population led us to a 35% increase in illness. Population growth added an extra 6% of illness on top of that. So in total, we've seen over the last 20 years or so, 32% increase in illness in Barbados. And we see similar or larger increases across the other Caribbean islands. So we're fighting the tide of aging, of course. Our public health actions need to generate greater health improvement if we're to offset that tide. That's an easy thing to say, of course. Let's recap that. National levels of illness are increasing. This is driven primarily by our aging population. Our public health gains, they have been considerable. Death rates are dropping and have dropped quite a lot, but not nearly enough to offset aging. Patterns of death and illness across the Caribbean is also changing. Rates of stroke, rates of heart disease are dropping, but rates of deaths and illness from falls, from dementias are increasing. So as well as our absolute burden of disease increasing, our pattern of disease is also changing fundamentally. So I want to just think about that for a little bit. This is all for discussion. The successes I've mentioned, we've lowered the rates of illness and death. This has led to higher life expectancy, and the successes are the mix of all the good things: public health improvement, healthcare improvement, wider social improvements. And it's those successes that have led us into our next challenges. We ideally, of course, all want to be older adults living illness-free lives, but on average, our data suggests this is probably not the case. Between 2000 and 2019, the number of years living with illness in Barbados has increased from 43 to 55,000. That's going to be repeated across the islands of the Caribbean. UHC, universal healthcare, is being touted globally as one weapon as we try to cope with age-related illness. But, and this in my opinion is a big but, any government's ability to pay for UHC is going to be hampered by demographics. Longer lives, fewer births. That means less people in the working population paying taxes and less money for the government to pay for healthcare. And then lastly, and what we know very little about, unfortunately, is the extent of multi-morbidity across the Caribbean. What we already do know from elsewhere is that it's likely to be the big healthcare challenge of our time, with dementias commonly part of that multi-morbidity mix. So this is more than a healthcare problem, isn't it? It's a challenge for all of society. And again, that's, gosh, it's a very easy thing to say, a very challenging thing to affect change. So I'm not even beginning to try and offer long-term and radical solutions, but in the short term, practically, what we might do is borrow a technique from climate change, which we've used a lot and seems to get attention at least. And that's simply to imagine what life might look like in 10, in 20, and 50 years' time under certain different conditions, if we cope well, if we do nothing, and so on. So the analysis I've just presented has given us some detail on a problem that really every clinician already knew existed, right? But those foresight scenarios, I think, are very good to begin a wider public conversation about the challenges we face. Then, and of course I'm biased, so I would say this, the second practical thing we can do is to monitor the healthcare actions more closely. We need more data on the problem itself, and we need more data on the actions we're taking to tackle the problems. So this leads me on to the project that we're currently running. And what we do know is that there is an awful lot that we don't know. The Caribbean has the lowest level of health data availability and accessibility in the world. There's good evidence for that, so I'm going to repeat it because it's quite a damning statement in some sense. The Caribbean has the lowest level of health data availability and accessibility in the world. And I'm just going to mention the project that we've started with IDB that helps with this problem. I'm not going to go as far as to say it is the solution, but hopefully it will be one little part of the solution. So it's called Carib Data. We're building a set of resources to enable and encourage Caribbean data sharing and data reuse, setting up an online infrastructure to enable researchers and others, communities, to enter data to collect their data more easily, to share their data easily. Developing a training program, longer term mentoring to increase capacity in data handling and data communication. Developing a different platform, all about data communications. This is about actively communicating the stories around the data we all produce. And at the same time, I hope, advocating for data reuse. And we're actively training data stakeholders. And the hope is that we build enough collaborations to develop something like a sustainable team of data storytellers. So just to finish up, right now in the Caribbean, I think it's fair to say that much of our data landscape is dominated by impacts from small groups and from individuals. We've got brilliant people, we've got some powerful data, but it's often siloed, fragmented, it's hard to access. So there's pockets of excellence, but they're usually operating in isolation, limited reach, and quite often limited long-term influence. So the hope, the vision for Carib Data and for other projects like us is to try to improve that situation just a little bit, create something approaching a regional collective for generating evidence. And I'll stop there. Thanks very much. Oh, last slide. That's the links that I talked about. So feel free to jump onto those. And we can share those later, of course, as well.
Thank you very much, Professor Hambleton, for that very instructive presentation. I must say that I thoroughly enjoyed it, and it has certainly brought to light the extent of work that's being done, and using the experience in Barbados as an example, and of course, what it could mean for the rest of the Caribbean as well. Noting also, I appreciated the fact that you were referring to the regional public goods. I'm not sure that the other audience might be familiar, but in the Caribbean, we do have what's called the Caribbean Cooperation in Health, which is a framework that allows for solidarity and exchanges in and around advancing health status in the Caribbean region. And in phase 4 of that, which goes until the end of this year, it looks at really delivering on regional public goods. So I certainly like the alignment, and it goes to show that from a policy perspective, there's a strong link there also with the work that that CARPHA does. Now, having said that, you also, just a quick comment, you raised something very important, which is the whole issue around data infrastructure landscape, the exchanges and getting there. And just to say that also, we experience a bit of difficulty in that. It's about changing what might be a cultural orientation about data and its use, and how we should build systems that would facilitate using what we have to better inform our actions, right? So it's a work in progress. I'm happy to know that we have more champions out there with whom we can liaise and certainly look to advance this, but certainly very well received. I'm just wondering, and of course, I, on a personal note, would love to follow up on this with you separately, but I'm just wondering whether there might be any quick questions, or if not, I think we will have a general session for exchanges on that. So at this time, I would yield back to my co-chair, Ishtar, to continue, please.
Thanks so much, Horace. And I just want to say, I'm totally on the same page in terms of the insightful contribution from Ian just now, because and I appreciate too, Ian, your emphasis on that statement about the Caribbean region having the lowest level of data availability and accessibility. And I also appreciate the solutions that Carib Data is offering, and see very rich syntheses and possibilities moving ahead, particularly in ensuring streamlining with CARPHA. Virginia, I see your hand. We're going to save the questions for after all the speakers. So keep track of that question or comment, because I know you're really ready to jump in from our follow-up from the last meeting. So we're going to move on to Dr. Seb Walsh. Dr. Walsh, or Seb, since I was corrected by Johnny. Dr. Seb, so as a public health doctor and a researcher, and you're working at this interface of epidemiology and policy, particularly keeping in mind some of the points that Ian was just raising in terms of data. So you've argued for a population lens on dementia and equitable approaches to prevention and care. So can you share a little bit with us about the public health strategies you see as most impactful for Caribbean countries, especially given the challenges that we're navigating with aging populations, limited resources, rising dementia burden, and this really, unfortunately, low level of data availability and accessibility? Over to you, Seb.
Thank you very much, Ishtar. Can you see the slides? Are they in, can you see them?
It's showing in speaker mode, so we're seeing the note section and presenter view. Okay, now see the full screen. Yeah.
Okay, thank you very much for the invitation to speak with you, and I think building nicely on from what Ian has just talked about. So I think that the question that comes out of his talk, or one of them at least, is in the knowledge that we are going to have more older people, which is something absolutely to be celebrated, and in the knowledge that dementia increases exponentially with age. So as you age 5 to 10 years, your risk of dementia doubles, or your likelihood of having dementia doubles. And that seems to be pretty consistent across geographical region, across time, where it has been looked at. The question is, how do we reduce the points on the exponential curve and lower risk as much as possible to offset as much of that aging demographic as possible? I think that's one angle for us to attack, and that's what I'm going to try and talk to in this in a few slides. The first thing to say is that it can be done. And these are data from Europe and from North America. Meta-analysis or population-based studies which have monitored dementia prevalence over time in standardized ways. And we've seen that the dementia incidence declined by about 13% per decade over the last 20, 30 years or so in those high-income contexts. So it can be done. And the question, of course, is how we do it. And in particular, in the regions like the Caribbean, where we need the most action. Most of you, I'm sure, will be familiar with this slide. This is the figure from the Lancet Commission, which has tried to address that question by giving us risk factors, which we think the evidence is sufficient to say these are causally related to dementia. If we were to address these 14 risk factors, we could reduce the amount of dementia in the population and lower the risk. And the question is how we do that. Well, how do we address these? And clearly data is a part of that, but a big thing is what the policy action is that we're calling for. And so Ishtar and I are both part of this initiative, this research group, PLADA, which is trying to answer that question from a population level approach, by which we mean changing conditions and environments to promote brain health and reduce dementia risk across the life course for everyone. And I'm very quickly going to run through 5 principles of that PLADA approach, which really illustrate what I'm talking about. So the first principle is that we need to be advocating for risk reduction. We have limited resources, as we've discussed. Clearly, we need a balanced approach, which includes supporting care systems. There will always be interest in drugs and biomarkers and diagnosis, and that's important. But we must keep advocating for the primary prevention, which is not the naturally loudest drum in the orchestra, but we must keep advocating for it and keep it as a policy priority. Second principle is about taking a life course approach. Dementia risk does not start when a person hits old age. It doesn't start when you're 65 or 70. Dementia risk builds slowly across the life course. Protective factors, brain health factors build slowly across the life course. And so our prevention approach has to take that into account for individual people, but also for generations and across society. So the metaphor here is to imagine that society is full of trees with the fruits of that tree being healthy brains, being lower dementia risk. And even if we're effective at trying to support individual people with individual pathologies, if we don't correct the deep structural roots, for example, that John was talking about at the start, the next generation will come through with the same problems. And so we must think more profound about those conditions, about those environments, not just for the current generation, but for the one after that. And related to that is this idea of risk being a continuum. So if we were to have perfect data in the Caribbean, which we don't, if we were to risk profile every single person for their dementia risk against those Lancet Commission risk factors, and we worked out that there was a group of people who had all of the risk, they were very high risk for dementia, maybe their risk is 5 or 10 times higher than the general population. And if we were successful in lowering their risk and truncating the distribution, that would be great. However, the data, well, the evidence and the theory is that actually the vast majority of the population are in the center of this distribution. And so although each of those individual people has quite a low risk, collectively, that's where the majority of our cases come from. And in the UK, where we've looked at it, up to 90% of cases are coming from this middle group of people who we won't include in any of our high-risk approaches. So policy-wise, what this looks like is, of course, treating the people with very high blood pressure, of course, but also trying to say lower salt intake across the population so that everybody's blood pressure comes down a little and you lower risk more efficiently that way. The last point is a point on equity, which Ishtar mentioned. So if we think about the environments that we live in, creating hurdles, barriers to us living with good brain health, they can be put relatively small barriers in the way. So if the food environment and the physical environment and the opportunities for education and work, if they are health promoting, it can be easy for us with our lifestyle interventions, with our medical interventions, to help people live brain healthy lives to lower dementia risk. But those living in more disadvantaged backgrounds where the risk is highest, will always be much more difficult to get them over those barriers. And so what we're really advocating for in Pladda is trying to lower the gradient of these hills, trying to lower the barriers through condition change, through environment change. So 5 principles, I think, really summed up by that tree metaphor. What that looks like in terms of research, we've done a deep dive into evidence against these risk factors of dementia for interventions which have been shown to lower the dementia risk and meet all of those 5 principles. And these are too small, I'm sure, for everybody and too busy to read, but the reference is here, and I'm very happy to meet with people offline to discuss in more detail. They're color-coded, and you can see that we've got a real good mix of data from different geographical areas, including low and middle income settings. Just to pull a few examples out, we're talking about things like taxation policy on tobacco, alcohol, and sugar-sweetened beverages, which I know has been a focus for CARPHA and others in the region. Increasingly, we're thinking about air pollution and public health and how to lower things like traffic density in urban areas through low emission zones. Cochrane review level evidence that this can lower air pollution, and we're confident that that will lead to a reduction in dementia risk. And then also things like legislative change. So going to work sites and mandating monitoring and reduction of noise exposure, providing adequate hearing protection has been shown to halve the instance of hearing impairment. And for each of those interventions, if you go to the reference, we've given full information on the size of effect to inform modelling approaches, but also the source of evidence and the key contextual information. For example, what kind of settings has this been shown to work in, and key implementation guidance. So just returning to that sort of central question, how do we reduce dementia risk in the Caribbean as much as possible? I totally agree that we need the data to know what the biggest risk factors are, to be able to model the effects with non-communicable disease and think through the implications of an aging society. But I hope that I've convinced you that taking this population level approach and following those principles should be the key framework that we build upon as we try and tackle NCDs and dementia together in a synergistic way.
Thank you so much, Seb. That was, as usual, every time every time we go over these points, I find it very sobering and eye-opening. And I think, again, very aligned with where the Caribbean as a region needs to go. We need policy measures that really can shift the population burden. And I think your overview of what those possibilities are, drawing from the evidence and what has already worked, is very timely, especially in the context of the overview of the data that Ian provided us. And also, as you referenced as well, Johnny's reminder of these structural inequalities, and in the Caribbean, particularly with our history of colonialism and the embedded, the deeply ingrained structural inequities in the system, we do need policy level shifts. So I'm really looking forward to seeing how today's conversation opens up for that. I will now yield to my co-chair so that he can introduce our next speaker.
Thank you very much, Ishtar, and I also thank Seb for the delivery that was done only a few seconds ago. Having said that, I think that we're well positioned now to take the presentation from Mr. Avinash Saxena. So Mr. Saxena is someone who has built health information platforms across markets from Asia to the Caribbean. So that's covering quite a bit of geography there. And also as a result, he has emphasized the importance of public-private partnerships, patient-centric data systems, and scalable digital infrastructure. So my question to Mr. Saxena is, how can we adapt these strategies to overcome the Caribbean's structural, regulatory, and adoption challenges in preparing for dementia and broader aging-related healthcare needs? Over to you, please, when ready. Thanks.
Thank you, Dr. Cox, and thanks, Ishtar, for having me here and giving me an opportunity to talk. I don't have a presentation. I get what I call as a brain freeze when I see slides. I'm better off talking, so I thought, let me just put across my thoughts. We started with what John said about inequality from a race perspective. Then Ian brought up a very valid point, which is data not being there. Or I should put it across, data is there, but data is sitting in silos in different forms where we can't just access it. Apart from that, there is a wider dialogue about policies, influence. Yes, we all know the need of data access, but what can be done? Then there are, I'll say trust deficit, and that's a fact. What we see is there is a trust deficit between we as professionals, as health professionals, sharing our own data. And that's one of the reasons I think we sit together, we sit on our data and that data is not exchanged. But what happens is it impacts patient care. What happens is the center of everything, what we are talking about here is patient. And in reality, the data belongs to the patient. We all, in some or the other form, are custodians of the data, right? The data belongs to the patient. So in our journey, when we started focusing on how this can be done, what we realized that all these approaches can be done, influenced, and can take effect if an ecosystem is created, which obviously we are talking of from a physical infrastructure perspective, but we need a digital universe of the digital ecosystem sitting on top of it, where there is a seamless exchange of data which can happen from when the data is generated at the medical professionals level and the different service providers who are aiding, whether in diagnosis or in providing services. How can that be created? So that was the advent of Daisy Health system, what we came up with. And it's a digital health ecosystem where patient is the center. It is very, very relevant that the type of era we live in, we are very much heavy on uh, data exchange, what is happening, but is it happening at health level? No. Again, why? What I said, trust deficit, because uh, is a consent mechanism being drawn? Is it being exercised properly? Does the patient have the rights to move that data when it is to be accessed? In reality, does the patient even have the access to his own data? And that's how when we created Daisy, it was created with all those consent mechanisms, all those security features drawn, the hierarchical data access process. It connects not just a clinic as a system, but outside, where two medical professionals can chat, can exchange digitally the data, can exchange permissions digitally. As of now, if we look at not just Jamaica, but from our own whole Caribbean system, if say Ishtar is my physician and Dr. Cox is my psychiatrist, and some data exchange has to happen, Dr. Cox has to write to Ishtar. From a policy perspective, what leeway we have is it can take 5 to 7 days to create a data in a file, right, which can go. That delays is if there is something which has to be addressed immediately and then there is a gap of data, it creates two type of burdens. One, lack of data. There is a bit of a hit and trial method. What we do as medical professionals, we have to cross check that continuously, right? And it can, if it is an emergency, we might have to aid to certain type of diagnostics procedures and lab tests and everything what we have done, which might already be available as a data somewhere else sitting, right? Daisy was created to address that need, where just on a click of a button on a real-time basis, the data exchange can happen. There is no need for, in terms of somebody picking up a phone or somebody writing a letter explaining something. The data file and a data docket can be created and can be transmitted digitally. So that was one of the reasons. And Daisy came out of my personal experience. I had met with an accident in the US. I called up my physicians and all other related entities in Jamaica to get my data, because I was given an opportunity that if I can get all my data in, things can be done, and I could have saved some money for my treatment, which was happening there. Somehow I didn't got access to my own data. And that is what triggered the thought that I have to come up with. Another portion of it was, when we talk of these health systems, these are pretty heavy on infrastructure, not just the centralized infrastructure. Centralized infrastructures will always be heavy. But at the user level, how light and nimble can we make them, right? So that when adoption, the question of adoption comes in, it also is something which is, the decision is based on what is the cost involved for me to adopt the system. What is the infrastructure I have to put locally to be able to access and use the system? And that's where DAISY addresses that portion, where you don't need to have a heavy infrastructure, digital infrastructure, hardware infrastructure within your clinic and your system. And it's a cloud-based system, absolutely secure. It is one of the system which is 2048-bit encrypted, and it's an end-to-end encryption. So I don't want to get into the technical terms, but it is something that gives confidence to people. It is one system which is had been tested and is ISO certified. So, but there were reasons why we did that, and DAISY is one of the solutions. I'm not saying the only solution. DAISY can be one of the solution of the whole ecosystem. When we talk of ecosystems, how it can connect data, how it can facilitate the flow of data between professionals. But the bigger question comes in from a policy perspective, right? When we talk of public-private partnerships, again, there is a deficit of trust, and I see that on a daily basis when we get into this conversation. Private sector and public sector, are we exchanging data? Answer is no. Are we ready to exchange data? That is a bigger question. We are not. I'll tell you, and I'm sorry if I say something, because that's how I have experienced it, but I'm a straight shooter, but that's a reality. We don't. Yes, we talk of data, and the reality is public sector sits on a way bigger chunk of data, right? Because it has been there. Private sector sits on the data based on our socio-economic environment. When I talk of Caribbean, right? It's only on an average, only 22% of the population is insured, right? Who can afford any type of treatment, can go to any doctor. Most of them would be concerned about and will go to the public health system. That's where the role of public-private partnerships comes in, whether it is from the data infrastructure perspective, whether it is the exchange. And in reality, public sector or the governments are the regulators. They have to put the policies in place. What types of policies have to be put in place is the question. How can private sector play a role in it? What role can we play? Obviously, we all know there are benefits of when these partnerships come together. It's a better service what we can give. There are improved efficiencies what we are looking at. We're looking at better outcomes. Ian again was pointing out about the gap and the projects what they have been doing. But the bigger question what we have to ask is, as a political will, is something happening? Yes, there is a lot happening. Is it happening at the right pace? I'm sorry, no. I can talk it out of my own experience. DAISY was launched in Jamaica in 2019. The first bottleneck what it hit was e-prescription. Oh, because the e-prescription legislation didn't exist. Was the work was being done on it? Yes, they were working on it. We are sitting in 2025, the legislation still does not exist. There were multiple committees which were working on it. Certain committees were abolished. A new task force was established. But yes, work is in progress. It is way slower. I have always said, and whenever I have had conversations about public-private partnerships and policy changes, I have said that we are not big enough to be fragmented in terms of the type of policies what we are going to adapt. like Dr. Cox was saying, as CARPHA, as the public health agency, right, driving a consensus on the different type of legislations needs, what can be done at a Caribbean level. Can we create a policy from a data exchange perspective, from a digital health policy perspective at Caribbean level, right? Where the stakeholders from private sector as well as public sector, they come together, right? They talk about, and it is not just the medical professionals, but the service providers, because they have their own concerns. Their concerns are about business, right? Because if they are going to invest money, am I going to lose business? Because my data is in the open space, how that can be done. And that is where agencies like CARPHA, agencies like PAHO, IDB has been investing a lot in bringing in different projects across the Caribbean. I've been involved in few of the projects. But that is something which is a bigger need. And that's where I think public-private partnerships are the most, whether it is to set up a physical infrastructure of the facilities or the digital infrastructure. Both the sectors have to come together. There is no question about it. And just last, what we are talking of, we are talking of on the World Dementia Council, the Caribbean chapter, the dialogue, right? I think we all know one of the issues what people face is we have to give data in people's hand. That's what introduces ownership. That's what introduces better care opportunities, access. It introduces control. The moment ownership is there, there is least of finger pointing at each other, right? And that's what we have to do. There is a question what I ask everyone when I'm talking to them about data, because everybody says, oh, health data is too sensitive, right? We cannot put it there. Can you please tell me your financial data, what you're doing right now, the number of transactions, what happened there? You are going to a restaurant, you're going to a party, you are going somewhere. All of your digital footprint is sitting there. Are we talking of privacy invasion? Have we thought it from that angle, right? So it's something which is consensus and awareness both, which have to be raised and driven together. And that was one of the ideas when DAISY was created, was to create that ecosystem which can give that comfort, which can drive something where data exchange can be there. We can digitize whatever data is there, can put it into the system, then take the step of from digitizing it to digitalizing it so that analysis can be done, right? And better decisions can be taken at the right time and in an apt time. So that's something from me. Back to you, Dr. Cox.
Thank you very much for that. I must say, I know you offered apologies, but I am thankful that you certainly have been directing your delivery. I think it can certainly stimulate discussion and we can have exchanges. I was making a few points for the discussion session, so looking forward to engaging you then, but certainly intriguing and very happy to have your perspective. I think it certainly helps to advance the conversation on this important issue. All right. So at this time, I will, Ishtar, I'm not sure, do we have another speaker
we
before
do.
we move to
So
discussion?
I can
Okay, good.
introduce
I'll yield to
Chelsea.
you. Thank you.
Thanks, Horace. And I also want to say, Avinash, I appreciated that, as I do every time we speak, your frankness. I do think we have a wider conversation when the floor opens in terms of why the Caribbean tends to lag behind in terms of the innovation space and what would be gained by the Caribbean really functioning as a collective market space, because you and I have had those types of conversations before. So I'm going to now move to Dr. Chelsea Garcia. Dr. Garcia has done a lot of work and innovation in the space of Trinidad and has actually set some standards for wider Caribbean models. She returned to Trinidad after spending some time abroad training, like many of us have done. And Chelsea, when you were away and then you returned, you adapted models from high resource settings to create this homegrown multidisciplinary care platform for aging and chronically ill persons in Trinidad. So we'd love if you would share some lessons with us about what you've learned from building community-based scalable care models and how these can shape national policy and advocacy for dementia care in the Caribbean. Chelsea, over to you. And Laura, I believe you'll be, yes, sharing slides. Chelsea, you're muted still.
Hello, everyone. It's an honor to be here today. Thank you, Ishtar, for that lovely introduction. Yes, I'm very fortunate to be trained in multiple different countries, so Europe, America, and my baby, the Caribbean. And these experiences have really allowed me to be exposed to different healthcare models and see what works and see what doesn't work. And that really does help me to take these high resource models and to create healthcare solutions for our limited resource settings in the Caribbean. And as Avinash presented before, it is highly frustrating, right? So let me just start with that. But I do love improving access to home-based multidisciplinary care. I love reducing costs. I love enhancing the patient experience. And in addition to my love for home care, healthcare strategy, really my heart lies in the Caribbean island of Trinidad. So that's why I do all that I do. So just taking it over to, it's been 5 years since I returned to Trinidad. So as I said, it's really been a journey. It's not for the faint of heart. And not only did I have to set up this healthcare model, which is specifically focused on home healthcare, but I really had to expand geographically in a very short space of time, build a team, train an entire team when many of the team members needed to be trained really from the start. That team now includes clinical palliative pharmacists, therapists, RNs, palliative trained caregivers. We have a team of 6 doctors, all really working together as a cohesive multidisciplinary unit. But it's also changing a culture of teamwork. I think Avinash alluded to the fact that we have data in the public and we have data in the private, and it's so difficult to mesh. And I know you're speaking of data, but it's also culturally, there tends to be that division as well. And it's breaking down those barriers, which are also not easy. So on one hand, you're training medically, but on the other hand, you're also training professionally. You're training on what is a team and how can we really collaborate together. Because if there's one thing I've learned specifically in home care medicine, it really is a team that you need to really deliver that comprehensive care. And every team member, whether you're a pharmacist dropping medication or a caregiver in the home or a therapist, you're trained in which I call the generability, right? And that is really just to recognize clinical red flags so that at every touch point, we're expanding care. And to be honest, I've been very surprised by our improved patient outcomes. Our patients that get this personalized care in their home, they really do they live longer, right? And they really do have a great quality of life. And this was something that I am actually new to, because having trained away, a lot of my patients, I would expect their prognosis to be less. But bringing the care to them is extending their prognosis, extending their quality. And we've had over 1,452 hospital avoidances just in 2024 alone. So I'd say this is truly testament to our quality of care, with 98% of our patients dying at home and 100% of them having advanced directives, and truly very detailed care plans that really allow home care to be possible. And really, when implemented effectively and efficiently, which is a hard thing to do, home care could save governments millions by preventing hospitalizations. And really, community care doesn't stop at the doorstep. It includes assisted living, retirement communities, and these serve as training grounds for both the medical professionals and the caregivers that we want to build that long-term capacity. And beyond the cost-saving benefits, there really is an emotional value to home care. I mean, consider a dementia patient at home surrounded by love, her children, her grandchildren. They learn empathy just by being close and participating in her care. It empowers that unit. It really creates a powerful cycle of care where families and communities grow stronger together. Communities like mine, which are plagued by crime, this solves more problems than just healthcare. And really, it has been beautiful to see this unfold, and even to see the low socioeconomic profiles of our caregivers really rise and really own their skill and rise professionally. And when you integrate young people into these systems, you don't just build care models, but you do build a community. And to me, that's the future of healthcare. Maximizing these limited resources is really essential. We have 3 initiatives that I just wanted to touch on today, just showing, how we were able to maximize those resources. And that is the Living Waters Hospice Remed Program. So this is a partnership that we did with the Living Waters Hospice, which is an NGO. We felt like there was a great need for recycling almost and redistributing of medications. Of course, our patients die or medications are deprescribed. And in 2024, we were able to donate in the first year of this collaboration, 450,000 TT dollars in donated medication. So this is an idea and an opportunity that just sprung from really trying to meet the needs of this low resource setting. Other things that came from this was the Live Health Charitable Foundation. Again, this is a separate NGO that was built for patients because yes, we are a private company, but that doesn't mean that we don't want to meet the needs of everyone. So we established a Live Health Charitable Foundation for persons that cannot afford, but are more on the end of home hospice, but do want to die in their home with dignity and comfort. And that is an initiative now that has been in existence for 3 years and has really been doing an exceptional job. Other things that really flowed from this is difficulty in the grief and bereavement and counseling and support that family members and caregivers need in the home. One of those things that I established was a workbook. A lot of these things that you hear me talk about, it's not me that established it. Honestly, it really is our team and our patients. So our patients who are actually giving us feedback, our patients have been instrumental in actually designing a lot of these things because many of them are or have been professionals in their own field. And the Becoming Me book is basically a workbook that I use to expand care because there tends to be a stigma in Trinidad and the wider Caribbean to counseling support services. So it's a way to allow that to be possible without having to have the patient have the expense of a counselor or a psychologist come to the home. And in addition to all that, when searching for an ideal health system, so we're talking about a home healthcare service, we're talking about doctors, nurses, we're talking about all these moving parts. And as Avinash alluded as well, you need an electronic health system to bring this all together in order to really bridge that significant gap. Now, unfortunately, I had searched far and wide for electronic health system that could truly be adapted to what I needed, and I was not able to find that. So I had to create my own to really give me that efficiency and that ability to operate outside a traditional hospital setting. And that is where LiveE was born. And it really took an existing system and we built it primarily not only for a solution to integrate the pharmacy services, but billing, human resources, KPI management, and really mobile friendly for the teams in the field. So it's actually built to be done on your phone because our teams are in the field. And that's a picture of our record there. Watching the slides there. And so here you will see the limited resources that we worked on, the different projects. And one of the things that this electronic health system is able to do is really track these key performance indicators. For me, when you're trying to strategize, the human resource element added in was very essential here. It allows for the strategic decisions in terms of financial projections, as well as knowing when it's time to hire another RN, add a position, replenish critical inventory. What if a hurricane comes and we need to be able to access who has oxygen in the home? If I'm going to be able to tell somebody that I'm going to save on hospitalizations and I'm going to tell somebody that, you're DNH, you're not for hospitalizations, I really have to equip their home with everything needed. And in the face of a natural disaster, to prepare for that as well. So this is something that we've developed over the last 5 years, and we have been very proud of. And now I also want to speak to caregiving as a foundation. So one of the things I learned here and early in the course of Live Health, I learned that caregivers, and when I say caregivers, I don't mean registered nurses. I mean formal caregivers, which means persons that you pay in the home to care for your loved ones in the home. This really is the most essential foundational element in any home care delivery. And from here and realizing this, we realized there was a great need to train these caregivers. And that's what really bore our in-home advanced certificate for caregivers in general in palliative care. And we had the support of the IDB to really bring this to scale. And this is something that I could tell you, I've just seen so much progress in such a short period of time. And for me, training internationally, other models that I've worked in, we tend to use RNs in the home. For us in the Caribbean, we don't have the cost. We have to save as cost effectively as possible. And this is really that scalable care delivery that really continues to maintain the premier support that you want for your patients. I'm not saying we don't utilize RNs for skilled needs, but this is something that has really created a lot of cost savings. Other than that, we're not just training these caregivers, we're uplifting these individuals from the low socioeconomic backgrounds. So we're giving them a chance to share their experiences, we're teaching it, and as I alluded, we're creating these strong community-based networks and changing culture, which doesn't happen over time, but it does happen slowly. And we're also combating this epidemic of elderly isolation that our patients face, and ensuring that these elders are cared for, seen, valued. This here is a picture of our recent caregiving training cohort that just went off. And it just shows that it's only up from here, right? But these caregivers are really something that we are heavily invested in and we're seeing is going to help really meet the needs of our palliative patients. Despite the lack of policy, advocacy surely exists. So as you can see, we're strong advocates. I believe everybody on this call are strong advocates. And yes, we strongly agree in integration within the home care. We do not currently have home care policies, especially since, as you all know, the global population aging is accelerating. So this is something that is greatly needed. As Saint Francis of Assisi once said, start by doing what's necessary. And that's where we started. And then do what's possible, take it one day at a time, and suddenly you're doing the impossible. And the truth is, the impossible cannot be done alone. Here we've created a scalable blueprint to strengthen geriatric, palliative, and hospice home medical systems across the region. Next up is Live Health Barbados. And we really look forward to collaborating with all of you, more people, more organizations, to expand our vision. But also, we're open to all the opportunities that unfold and learning from each and every one of you. So I just want to end by thanking Ishtar for having me and the World Dementia Council for inviting me. I'm happy to answer any questions. If anybody wants to have meetings after this, I'm happy to meet with you and see how we could collaborate.
Super. Thank you so much, Chelsea. I'm hearing a little bit of an echo. Can you hear me clearly?
Yes.
Okay. You want to mute your speaker while I'm talking, Chelsea? Thank you. Yes. So I will share very personally that Chelsea and the Live Health team have been absolutely phenomenal in helping manage my mom's care in Trinidad. We were at our wits' end because she was in the public healthcare system and at various clinics, and we were having a horrible time at the end of last year, beginning of this year, in terms of her pharmacological management, because she'd be at one clinic and be prescribed something, another clinic prescribed something, another clinic prescribed something. And just in the running around with all of the clinics, it was exhausting for the family. It was exhausting for the health providers because they did not even have a sense, as we talked about in the first dialogue a couple of weeks back, of which medications were in stock. So it kept being this volleying. We would go to the provider, we would go to the pharmacy, we would go back to the provider, we would go to the pharmacy. We don't have time like that. I mean, and this is the challenge of relying strictly on public health and private care being inaccessible. So a special shout out to Chelsea and that team, especially with the foundation, because I think it presents a model that can potentially work. You can have private sector companies that have foundation and not-for-profit aspects. We have a plethora of expertise represented by other people on today's call, and that includes media, that includes neuropsychology, that includes psychiatry, and that includes researchers. So I would like to, at this point in time, open the floor to anyone who would like to respond to anything that was said, to raise other questions, other concerns, and to have further dialogue. We have approximately half an hour or so, half an hour to 40 minutes in terms of additional time for dialogue. So please feel free to raise your hand or open your mic. Again, as a reminder, what we're doing here is really figuring out how can we improve readiness? How can we really use these types of contexts for advancement? Claire, over to you.
Good morning, everyone. I am not a doctor of any kind of medical influence at all. So outside of my son, involvement is in media. And listening to everything that was said, and I also have parents that have had dementia and have passed in the last 2 years. And the last speaker, I could really relate to a lot of what was being said about the importance of the home care, because we were able to put that together and it really made a lot of difference. But going straight to where my discipline speaks to this, one of the biggest issues, I believe, as one who has been intimate with the experience, and therefore when you're intimate with the experience, obviously it brings a different sense of awareness with it, is that I think to move the needle on what is happening in the Caribbean, you need to have a perception change within our audience, right? And that perception change, from my perspective, happens when people are able to appreciate its relevance. That's really how people change. That's how media works. That's why we watch certain shows. That's why we go out and buy certain things, because we see it to be relevant to us. Now, the challenge that you have with this particular condition is that you're going along and you're 18, 19, 20, and people talk about old people have these things happening to them, and you see it with their grandparents or whatever. It doesn't actually hit you until you actually have a relative that you see happening to our loved one. So how do we short circuit that? There has to be a thinking around how we get the relevance of this to hit somebody in their 20s. Anything else you're doing, in my estimation, is just continuing to manage it when it's way down the road. So I would say I become aware of this in my 50s, because that's when my parents are hit by it, at which point Ishtar, we have a conversation and she gives me this piece of information. You know, this is something that would have started 20 years ago, and I'm like, what? I begin to think back and I'm able to piece things together. I say, oh yeah, they were doing this and they were doing that. What a difference it would have made if 20 years before I did recognize this, right? So I would say, Horace, when you think about regionally, how do we begin to really move the needle on this from looking at what we want to happen in the future? Obviously, I'm not saying drop your hands on everything that is going on now, but I'm saying the concentration around younger people and managing their perception of this issue by finding ways to show how it is relevant to them. It seems like a large task, but it really isn't, because, as I said, in the world of media, people do it every day. Amazon figures out a way for you to just keep buying things, even although you don't need them. It's part of how the world of media works. So I would say that what I would want us to think about is, if we're looking for indeed a longer term solution in terms of how does the Caribbean get around this thing, the question is, how do we address relevance? I would say, and I wrote it down as everybody was talking, policy does not drive relevance. At this level, we're here talking about these things as the people involved, you think about policy. Policy does not drive relevance. Relevance drives policy. And therefore, if we figure that out, it begins to change the perspective. Relevance and people knocking on their councillors' doors, talking about it with their MPs, that's what drives policy, not the other way around. I would also want to bring up the issue of, again, the relevance and how do we get the conversation going in the region. Mental health is taboo. Calling it mental health has made it worse. So the worst thing that has happened around trying to manage this particular issue is labeling it mental health. I don't know how you undo that, but I would suggest that you want to. You have something wrong with your foot, you don't call it foot health. You have something wrong with your hand, you don't call it hand health. So I'm not sure why we're calling this foot mental health, right? But that's one of the biggest issues. How do you get people to have the conversation around it? How do I know how serious it is? All right, I'm a graduate. I've done a doctorate in media. I am in a group with a bunch of doctors, dentists and CEOs for medical hospitals and stuff like that. All of us in the same age and all of us actually having somewhat similar issues with our parents. And we discuss everything else in a group. And very rarely in a group do we actually discuss this issue about our parents. It struck me how strange it was. Probably we'll break out one-on-one and talk about it, but as a group we don't, because for whatever reason in the region, there is a little embarrassment about this issue. There's a little shame around this issue. I would say that that is one of the things that you have to hit on forcefully to let people understand it is no different from any other illness that you might have. So I will not have the show anymore, Ishtar, but I just wanted to put those points on the table for us to give some consideration that when we're thinking about this issue, those are points that we need to look at.
Thanks, Claire. And again, your invaluable experience in media regionally, I take what you're saying very seriously. And we need to think about how we position the messaging around things and what larger campaigns could potentially look like. I know Horace, his connection dropped, so he's trying to get back in, but I'm sure he will have some other points to contribute in response. And I know he also had some contributions about Ian's and Avinash's presentations. Regina, you had wanted to make some comments earlier on, so over to you if you are able to open mic.
Hi, sure. Good morning, everyone. I'm Regina Horace. I'm a human geneticist at UWI. First of all, I really enjoyed all the presentations this morning. I thought you all shared really interesting and inspiring stories. I was wondering when Ian was speaking, clearly your data is showing that the population is aging. And, you spoke about this idea that when people, you didn't necessarily speak about this, but when people retire, we've all kind of seen anecdotally that suddenly they have, especially very high functioning people, they have this kind of quick cognitive decline because all of a sudden they're no longer relevant in society as they used to be, and they almost have this identity crisis. And one of the solutions has been to increase the retirement age, and I know some Caribbean countries have been playing with that a bit, and we tend to talk about that in the public sphere as a good way to get more funding for universal healthcare, etc. But has there been any data from any of these experiments where we've raised the retirement age slightly that show any correlation between increasing retirement age and then decreasing rates of dementia, or just people living better because they're working longer and having something to do, as opposed to retiring and becoming having this loss of identity, etc.
Boy, gosh, that's a great question. I suspect a good person to answer would be a health economist or an economist. I can fairly confidently tell you that there isn't anything across the Caribbean, but that's not to say that there isn't something relevant. The short answer is I don't know. There's data on there's population data actually also from the Caribbean on keeping active in your community after retirement, and I suspect
Yeah.
that's not a dissimilar process. You know, as someone that's approaching retirement, I would hate to think that the only way of avoiding dementia is to keep on working. Keeping active in the community, I would imagine, would be another very positive thing to try to do. There's definitely data on that. There's data across the Americas, and there was something called SARBE way back in 2000 that tackled those issues, and those data are openly available for people to look at and to use. I'd be surprised if there wasn't something elsewhere in Europe or the States, but I couldn't tell you for sure on that.
Seb, do you know if there's work in this area that we might be able to jump in with or replicate?
I've definitely seen some stuff from the States trying to unpick the question. I mean, from an academic perspective, the question is very hard to answer because you're trying to get rid of what we would see as reverse causality of people's cognition starting to fade and then they choose to retire for that reason. And you have a big gap between what we might be able to observe and then what you might actually intervene on. The idea that you change retirement age and that would lead to something. There's a big group at the minute funded by the US government, at least for now, looking at social policies, including around retirement and pension and welfare support in retirement, trying to map those policies globally. So not just in America, but it's US funded, and then try and track that against health and retirement study families studies, including in the Caribbean, to see if we can try and make that link. But I think the work at the minute has been focused on cognition as a hard outcome. And then there's a whole other literature about that sort of loss of status and all those important qualitative stuff. So I think academically, very complicated question to answer, big gap from observational data to what you would actually intervene on. I do think it talks to a bigger point though, which is that, as you mentioned, the public conversation about these things tends to be, you know, that old people are a drain on our pension systems, and if we can raise the retirement age, it will solve that bit, it will fund universal health coverage or whatever. And that speaks to a much bigger issue about ageism and you know, valuing older people and their contribution, and trying to reframe some of these conversations that actually an aging society is a massive success that we should be you know, celebrating, but it's about trying to add life to those years rather than just that. So yeah, can I just make one point on the previous point about the media, because I think that's a really interesting question, just while I have the mic. So in the UK, healthy life expectancy is going down. Life expectancy is no longer going up. And that, I think, should be like a national scandal that's on the front of every newspaper, because if that's not what we exist to try and achieve as a government, as a society, people being alive and being healthy, then I don't know what else we're here for. And we're getting worse. And it makes no media coverage at all. It makes no splash. So I totally agree that the relevance in the media conversation can drive the policy. But I think we have a major challenge about getting any health kind of macro lifestyle, life course and aging things into the media. If it's, you know, such a blunt metric like health and life expectancy, let alone trying to get to dementia. But one point I did want to make is that I don't think the solution is us trying to make 20 and 30-year-olds scared about dementia in order to try and drive a prevention agenda. I think that's the wrong approach. I think we can talk about brain health, and we can try and find positive markers of brain health, maybe with biomarkers and wearables and things that we can track and try and suggest that people are boosting that, say by good sleep hygiene or whatever. But I don't think we should be framing dementia prevention. I'm not sure that's what you were suggesting, but just to flag that, I think that's not what we should be talking about, because I don't think it will work. And even if it did, then we're just probably increasing stigma and probably not achieving what we want.
Thanks. I see Claire nodding her head, which is a good sign. When Claire nods her head, she's in agreement with you. Nakia, I see your hand up, and then Kimberly, and then I think we want to open that conversation as well after we hear from each of you about Horace. You had mentioned there were some questions and ideas that you were having in terms of how public and private can really work better, more effectively, particularly after you heard Ian's conversation and Avinash. And I know Chelsea has also provided some really concrete interventions. So Nakia, over to you.
Thank you, everyone. I really enjoyed the presentation. I'm Nikia Washi. I'm an assistant professor in the Department of Public Health at the University of Rhode Island. And I'm trained as a sociologist, but I do also population health research in this macro-micro assessments a lot and cross-nationally. So just as a quick follow-up, a general thought I had from Claire's comment and then Seb's comment just now in terms of the reframing or bringing the conversation to younger people. Yeah, I think I teach young people. They are very unaware in many ways of all dimensions of health. And I this term I taught a course on exploring global health introductory course, and even chronic diseases. Many students, we're talking young 20s, early 20s, 18, 19, just so unaware of even the leading chronic diseases, diabetes and cancer. And when Seb was speaking just now, it just reminded me of, at least in the US, there's been a lot of media coverage of increasing cancers amongst younger people. And that's coming from existing research. So in some degree, it would be very useful to have similar kind of media conversation about cognition broadly, not dementia, but just cognition, cognitive impairment, and the risks of that declining as we age, regardless of how young you are when you're receiving this information. So, I mean, there might be ways to think about doing that that's more on a lay level, lay public distribution of the existing research, even if it's not directly from Caribbean populations, but talk about it in the context of the implications for Caribbean populations. So that was a general thought coming out of what Seb just said and Claire's conversation. I had a specific question to Ian on the data. Can you give some examples of what sources of data are actually available in the Caribbean to assess risks of cognitive impairment, if not specifically dementia, because dementia it's clinically diagnosed, and then it gets into, for what might be available in the Caribbean is mainly patient level data, which is more difficult to access. With nationally representative population level data, we're generally able to look at risks of cognitive impairment because there might be batteries or even single questions to assess memory or some dimension of cognition. Do we have a sense, Ian, of what is actually available that can be accessed, even if not easily? Because easily is the challenge generally. But what might potentially be available to even look at this at a population level scale?
My short answer is that I'm not entirely sure. That's a useless answer, isn't it? I mean, the data
It's
I
a truthful
presented
answer. It's okay.
was absolutely open access, and it was WHO data and it was the UN data that we put together to provide very basic kind of national information on illness and on death. When it comes to the specifics of particular illnesses, you're always looking at far less accessibility. I mean, as Avinash said, this is an issue around, is it available? Often it's not, but sometimes it is, and accessibility then becomes a real problem. But Ishtar, has there been any national? There has been some, right, Ishtar?
Yeah, I think, and this is part of what we're wanting to make sure that we're starting to do work from now to highlight what some of these possibilities are with data, so that come next year at the Caribbean Brain Health Summit, we're showcasing what some of these things are. So we know that there are cross-sectional population level surveys. We have in Jamaica, the Jamaica Health and Lifestyle Survey. We have in Barbados, and Ian, you know those surveys better than I do. And we have in some Caribbean countries, we have the WHO STEP surveys. We have inconsistent, and Horace, you would probably be better able to speak to me in terms of what DHIS2 has, but we have inconsistency across Caribbean countries in terms of death registrations and in terms of national level prevalence and incidence data. And that speaks to a larger issue in terms of needing how we train people, how we train the medics in terms of recording deaths, how we train health professionals in terms of, even if you are not able to recognize a specific type of dementia, how do you record deaths by all-cause dementia? And all of that type of information would also give us a better insight into things. Horace, I see you've unmuted. Do you have a sense with the DHIS2 system?
Yeah, thanks so much, Ishtar. Just wanted to make a few quick contributions. I'll try to be very succinct because I appreciate that the conversation is going well and I see a few more hands. So one is that I thought Claire raised a really good point about the need to be able to package this in a way that's relevant to persons from a younger age. And there's where we speak more about the promotion and prevention component of it. And I think that from a policy perspective, it'd be interesting to see how the Caribbean Public Health Agency can consider what we could do in that arena so that we bring more awareness to this from an early age, so that one, even within the home setting, we get people to identify if it is that, there's some early signs there, and also we help persons to take the necessary precautions to try to slow the process to arriving there if it is they're going to get there. So I think certainly it allows for more discussion, and I took note of that. And I think it's an opportunity for us to do a deep dive at a later time. When Avinash presented, there was something that piqued my interest, and that followed from Ian's presentation, speaking about data infrastructure, etc. And then Avinash spoke about the tool or platform that they're offering with Daisy and how this can help to complement some things. One of the questions that I had is about standardization and harmonization, because as you mentioned, there are other tools and platforms that we use in the Caribbean. And just to say that even from a public health agency perspective, we find that even though we might recommend one, for example, the DHIS tool that has its own features, it's open source. You have many instances where different tools are being used in different member states. And in all honesty, each member state is at a different level in terms of the whole data architecture and management, etc. So DHIS is Digital District Health Information System, version 2, that's what we use. It was developed by University of Oslo, and it allows for data entry in the periphery as well as at central level, and also for some very basic and routine data analysis to be done. And as I mentioned, it's open source, so you have some member states that are using it across the board and others that are using it for specific disease profiles. So going back to what Avinash mentioned at a later time, I'd like if you can just comment quickly on the whole harmonization and how Daisy can integrate with these things. And if, for example, in the development and rollout, if they've considered how they can integrate same into what may be used elsewhere in other member states. And also, if there can be a short comment about whether or not, regarding the data privacy issues, I just wanted to say that look, this is a real issue. Member states have deep concerns about sharing data. And I'm transparent about it because it's something that we are challenged by at the Caribbean Public Health Agency. And to be sincere, we have to try to convince member states in some instances as to why they need to share data. And to put it into context, this is even related to infectious disease data. And as you know, that's a faster turnaround time and is more challenging, but there's some real data privacy concerns, and we've not been able to address them in their entirety as yet. So as we go to the non-communicable diseases, I can only foresee that it might become a bit more challenging because there might be less interest there and less infrastructure in place. So it is to say that these are ongoing issues, and we even recently discussed this at the executive board level and are taking it back to another governance level. So these are real challenges. So I say to say that you're not alone And even at the regional level, even though we're strong advocates, we're challenged by it too in a very significant way. So I'll just pause there for now, noting that there are many other hands and conversation is going well. Thanks.
Avinash, do you want to quickly respond before
Yeah,
we go to
yeah,
Kimberly?
absolutely. Absolutely. So what I would want to say, Horace, is one, what is important is, yes, DAISY is an ecosystem which was designed to exchange data, but it was kept in mind, and we knew that one system cannot serve all the geographies, even it has the capability. So what we made sure that it has all interoperability standards which were built into it, right? So whether it is HL7 version 2, HL7 FHIR, if need be, OpenEHR as a system can be done, right? It can be integrated. These are standard messaging systems. Once the systems are compliant to it, they can talk to each other. So data exchange can happen. The question of privacy, I think what is important is, one, we have to make sure that the systems what we are adopting are as per the standards of whether it is HIPAA regulations, right? Can their overall data sets, data infrastructures, what are being created, are they observing the GDPR regulation from a privacy perspective, where the personal health data and the personal identifying information, which is PHI and PII, they are kept separate, which obviously helps you when it comes to analytics. You can anonymize and de-anonymize the data pretty quickly because these are fragmented databases, right? This is something which can take place. Other portion is how secure are the system and how secure are the channels? Because the biggest challenge what we face is when you have on-prem systems, right? The security is absolutely the responsibility of the person sitting on the premises. Whereas when it comes to cloud-based systems or hybrid systems which interacts, there is a bigger infrastructure which can be taken care of, and encryption is something which works better in those type of environments. And that is something which we have to look at. Those are some few basics what we have to look at when we are getting exposed to or using the data. And definitely DAISY has the capability of integrating with any and every system, not just an EMR, an EHR. It can integrate to an existing pharmacy system, a radiology information system, a lab information system. It can integrate with any system, and it can flawlessly, the messaging can go across. The next question is what I said, and you just nailed it in the head, where data exchange. Governments, not just the governments, as public sector, they're not ready to share their data. And that's what in private sector we say, that public sector is a black hole. It's a one-way street. If the data goes in, it just gets absorbed, nothing comes out of it, right? And that's the irony for an emergency. If I am being admitted in a public health hospital, when I come out, except for my prescription, even the discharge summary is so skewed that nobody's even able to make sense of it, right? So what is important is that dialogue, and that's a policing thing, and that's where I think I will go to Dr. Grant's thing, relevance. What is the relevance of that data? Obviously, the data exchange has to happen for us to be able to continue the care. The continuum of care can only happen when the data is flowing across the realms. If it is not flowing across the realms, it is not going to happen. Plus, if you or all of us, right, we want to drive policy, we want to drive change, what we call it as the health of a nation or health of a region. How can we define health of the region if we don't know what is happening at different structures? And that is what we have been talking. I've been talking with the government of Jamaica as of now. There was a time when I was talking to even in Panama. Panama has its own issues, and we were trying to give them a solution as a unified system so that they don't have to use multiple systems. But that is something which we were talking to them. The data exchange has to happen. It cannot be one way, but trust efficient. The government, how they feel, what they feel about it. Private sector, it is about the dollars associated to the data which goes out, and if it is lost. I, as a businessman, if I see a patient as, I'm sorry, again, I'm saying something, but I see patient as that dollar bill which is being swiped, a card being swiped, a number coming in, right? That is being lost if data is exchanged. I think what we have to do is we have to look at a bigger picture. And again, I'll go back to what Dr. Grant was saying. Relevance. Relevance comes from awareness. Are we talking about this? Right? Yes, talking in this group of 30, 40, 50 people sitting, right? Yes, we all agree. I think we all are more or less on the same page. We know the need. But on the bigger things, are we talking about it openly? That awareness, patient to have the ownership, because the ownership of health has to be in patient's hand. Once you give that, and to answer, there was something which Rajni was saying, and Dr. Grant again was saying that, right? That at a younger age, oh, can we touch it?
Mm.
We might not be able to touch the dementia part of it, right? Like Dr. Walsh was saying, oh, we should not create a scare in somebody's mind at that age. But I'm sorry, there are those 14, 15 parameters, Dr. Walsh, what you showed, right? If as a group, we start working about those parameters, creating that NCD load, if we can manage that load, which has an impact eventually down the line in the age, right, on your mental health, that is something which can be looked at. So that's my idea. That's what I think. And it's more of what we are creating, all of us as creators, as innovators. I think one thing we have to has to come out of innovators' head that, oh, I'm going to control and rule the world. I use that very bluntly, right? Let's focus on increasing the size of the cake, not the size of pie what I have. Once we increase the size of the cake, automatically the size of the pie is going to go. So the more collaborations we are going to create, the systems which can interact with each other, not necessarily. That is something which we should drive as a message.
Thanks, Avinash. I want to hand over to Kimberly, but also want to mention this point that Seb was reminding in the chat about dementia diagnoses. And I know we have some people who are very involved in this. James, who's on the call, Annalisa, who's on the call as well, from Trinidad, and then Kaya and Javila, who are in Jamaica. But dementia diagnoses only show up from when people are actually accessing care. So surveys need to use these that we're relying on at the population level when we do studies like the health and retirement study and the harmonized cognitive assessment protocol. Those really need to have batteries that are culturally relevant, as well as the neuropsych assessments need to be culturally relevant. So data quality is key. I want to also note too that during COVID, Ian, I see your hand is up, but during COVID, Ian was really responsible with a team of people for providing the data. And I think that COVID period, and I know CARPHA really did a lot of work in that period to link trade, security, tourism, and health sector, and make data available in a timely fashion because of responsibilities for global reporting. And I think there are many transferable lessons from that period as well. Kimberly, over to you.
Thank you, Dr. Govia, and thank you for having this dialogue. It's been extremely enlightening for me. I have a few questions. I believe it was in Dr. Seb Walsh's presentation where there was a table with some interventions looking at the population approach. And I found that very interesting because a lot of them reminded me of something called the WHO Best Buys and the type of interventions that are there. What I wanted to ask about though is because in the NCD space, what we found, at least in Barbados, there's been some pushback, largely from industry's perspective. You know, the big food, the big beverage, big soda industry pushing back on really population policies that would help health. So I'm curious in this space, in the dementia, in the brain health space, how will those hurdles be overcome when you're looking specifically at dementia? Because when I looked at the list, I mean, it went by really quickly and it was small, but I saw on the list fiscal measures, fiscal interventions, and then at the other end, the legislative interventions stuck out to me because I see almost like the legislative interventions covering a lot of what is in the other column. So marketing that will require legal intervention or legislative change to do that. So I'm just really curious about how the dementia, the brain health space will accomplish that, because again, given I guess the history we have the story from the NCD space where there's been tremendous pushback. Even most frontal in my mind, I guess, is the front of package labeling process that we had. Here was a perfect opportunity as a region to come together and do something for public health. And today we still haven't managed to accomplish that. So I'm curious about that. And then my other question, so that's kind of like the focusing on the legislative framework and how we can do that. How can we get government support behind that? But then the other question I wanted to ask is about equity. And I think this was in Dr. Garcia's presentation, which was amazing, very eye-opening and very excellent work there in Trinidad. And I heard you mention Live Health Barbados, so I'm looking forward to that coming here as well. But I was curious to know, how do you ensure equity? Because at least in Barbados, the home health care model is extremely costly. So I'm curious to understand the funding mechanism. Is it, I know you said it's a private entity, but is there also government intervention, like subsidy support for those caregivers? And then two, what are you mentioned training for formal caregivers, but I'm curious to know about training for informal caregivers, because again, in Barbados, again, we lack the data as far as I know, but anecdotally, the majority of carers are informal. So they're family members caring for other family members who, in my mind, especially when it comes to the dementias, require training because it's very specific. So does your model also cover the informal caregiver? And I suppose this last question connects the two pieces from Dr. Walsh and Dr. Garcia in terms of interventions. Are there, I didn't recall seeing it in the list, but again, it went by very fast and it was small. Are there interventions for caregivers? I know in some regions, such as Asia, there are, fiscal policies for those in informal caregiving roles, so that there isn't that additional financial burden. You're already caring for someone who's living with one of the dementias, and it can be extremely taxing for a family to have to pull their pockets where they don't have universal health coverage and so on. So I'm curious to know about your thoughts about interventions for the caregivers to help the person living with the disease. Thank you. Over.
Thanks, Kimberly. Chelsea, are you able to speak?
Yes, thanks for that, Kimberly. That's a great question, and that is often something that we struggle here with as well. So when I say formal caregivers, so there's two types of caregivers. There's informal, which basically means family members and friends, which I think you're referring to. And then there's formal, which is someone, and this typically happens in the Caribbean, where they convert a housekeeper to care for their family members, or maybe they found someone that they say is a geriatric nurse and comes in to care for their family members. Now, what we experience is this is a very wide range of people and a very wide range of skill sets. And almost all of them have very good intentions and lack the education. Even the family members, the informal caregivers themselves. So yes, this advanced palliative certification is something that we created for the formal caregivers because we felt like there was a great need. But that still doesn't address what you're seeing, because a large majority of people cannot afford to pay for these formal caregivers in the home at hourly rates. Some of them need, 12-hour shifts every day. Some of them need 24/7 shifts every day. And this really causes really an increase in financial suffering. Now, we have also launched a course through the IDB funded for informal caregivers, such as family members as well as volunteers. And that is something even family members could do the advanced certificates, because even if you have a dementia patient and you are the daughter caring for them, but let's say you're taking time off of work to do it, you want to do it, you're dedicated to this, you will really need more formal training in everything that prevents at home, especially if you're the main carer. At this time, that course is a 4-month course. And that does take a lot for a family member now on top of having to care for their loved one to come and really learn all these skills. And these skills are really attributed to home management. So whether it's aspiration prevention, whether it's pressure ulcer prevention, it's taught by occupational therapists, speech and language therapists, and it's so needed. So we will skim it down for the family caregiver course, but for somebody who's really acutely taking on that care, I would recommend that they do the advanced course. But all these things are in the works. These courses have been rolled out, and they're continuing to be redefined and readapted. And it's something that we will offer to Barbados as well, because we know that no one could offer true home care without giving those caregivers the support they need and the training.
Thanks, Chelsea. I know we're practically at time, so I want to, Kimberly, I think the whole purpose of today is really to continue this conversation, and there are going to be tons of other follow-up conversations, I'm confident. But I do want to make sure that we have time to hear from Diego and Ian before we start to wrap up. Diego?
Thank you. I'm really conscious of the time, so just wanted to say that it's been great to hear all of you. I'm Diego Aguilar, Regional Director for the Americas at ADI. And I would really like to stress the place of civil society, the role of civil society in driving policy, which I think is fundamental when we talk, especially in the Caribbean, and how we can kind of anchor community culture through civil society, because really civil societies in the Caribbean are often really embedded in local communities. So I think it's a way really to understand dementia in the Caribbean, and how we can help develop culturally relevant models of care. And I think care is really important here. And we have to remind ourselves constantly that care is really the heart of the whole process, and how really civil society drives for change, and how and I do really agree with Dr. Grant that changes are really driven from community, and I think this is really important, and we always have to keep it in mind. Thank you.
Thanks, Diego. I also want to shout out the Healthy Caribbean Coalition, which is a regional organization that's an umbrella organization for civil society organizations. Works very closely with CARPHA, we've worked very closely with them over the last couple of decades on multiple efforts, and they're serious champions. Ian, over to you. Last word to you before we wrap up.
Again, I know there's just a couple of minutes, so I've got 3 points, far too many, so I'm going to be incredibly brief without really any context, so apologies for this, but we can chat later. The first one is just to say that I think it's always going to be a stretch in the current climate of funding, data funding, health funding, to think about and to set up new data collection structures. What we do have, and what countries are already all bought into, is, as you said, Ishtar, the STEP survey, and you reminded me of this. All countries run the STEP survey. STEPS does not have a module for health among older adults. It absolutely should do. There's no reason why we can't add it just within the Caribbean. So it's something to think about. We've talked a lot about the lack of data availability and the lack of data accessibility, and there's always a danger in starting to become a very negative discussion, about how people almost don't want to do it. And I just want to remind us all that this is very much linked to the issue of statistical capacity across the region. I do not think that it's the issue that governments don't want to share. I think there are daily tasks that take us away from the important act of sharing. I've got a colleague at the Ministry of Health and Wellness in Barbados, just one full-time statistician. She has to report on 400 metrics to different development agencies in the course of a year. There isn't much time to do much else. So it's just to bear that in mind. And then we also, me included, we talk about the reticence on sharing. What I don't think we've done as academics, and I may be tainting everyone with my own kind of low standards here, but what we haven't done as academics is show the benefits of data reuse in meaningful ways. So we're not the only people trying to do this now, but the Carib Data Project, we're recognizing that we're not particularly good at it. We're linking up with journalists, and hopefully we'll start to tell positive stories, or at least stories, and show positive uses of data. So yeah, that's the points for me.
Thank you very much. We are totally on the same page in terms of the importance of media, and looking forward to some follow-up conversations around that. So I want to say thank you all for your time, your insight, and your generosity today. Every day we are reminded of the crucial importance of this work that we do. Just this morning, there was a news report of US comedian Jay Leno's journey as a carer for his wife, Mavis, who is living with dementia. And according to Jay Leno, when you get married, you sort of take a vow. Will I live up to this? So it's basically what we did before, except now I have to feed her and do all those things. I like taking care of her. She's a very independent woman, so I like that I'm needed. You have to find the humor, he said. So Jay's comments, I'm sure, ring true for many of us. There are challenges for sure, but we need to find the humor, the positive aspects of approaching dementia, and also be able to dialogue and learn from others who are also on this journey. And that is precisely what we did today. Together, we've uncovered some urgent questions about how the Caribbean can lead, not just catch up, when it comes to shaping a brain health agenda that reflects our histories, cultures, and strengths. We heard powerful messages about the urgency of shifting policy priorities in step with demographic realities, the need to embed brain health in broader public health frameworks, the promise and complexity of public-private partnerships in innovation and access, the essential role of storytelling and Caribbean realities in changing public attitudes, and the importance of regional solidarity in creating scale, credibility, and impact. What stands out most to me is this: there is no lack of talent, insight, or effort in the Caribbean. What we need are spaces of purposeful dialogue like this one for alignment, action, and amplification. So as we close, I encourage you to stay connected with each other and with this process. A very special thank you to our speakers for giving so generously of your time and experience. A special thanks to my co-chair, Dr. Cox, and to the World Dementia Council team, and to each of you who showed up ready to contribute. You have helped set the stage for what's next. So let's keep building, let's keep showing what's possible when the Caribbean leads. So until next time, thank you and take good care.
Take care, everyone. Thank you. Bye.